Hi everyone, this is Galang-Gatbonton and we will be discussing life-maintaining interventions. Also called as life-sustaining interventions or life-sustaining treatment, these are any treatment that serves to prolong life without reversing the underlying medical condition. It may include, but is not limited to, mechanical ventilation, hemodynamic monitoring, fluid and electrolyte balance, acid and base balance, pharmacologic interventions, and may also include renal dialysis, artificial nutrition and hydration, among others. First is mechanical ventilation. It's a medical term for using an artificial lung machine to fully or partially provide ventilation by helping move air in and out of the lungs. Mechanical ventilation is basically indicated when a patient's spontaneous breathing is inadequate to maintain life. In the photo, you can see one of the many designs of a mechanical ventilator, or sometimes called a respirator. But regardless of the design, its main goal is delivery of oxygen and/or removal of carbon dioxide through the airway. It consists of many parts, but mainly a respirator has number one, monitor. There is FiO2, PIP, PEEP, and RR as its usual settings. FiO2 is partial oxygen pressure in percent. Lowest possible is 30% and highest possible is 100%. Please take note that the Earth's atmosphere is 21% oxygen. So if you need higher amounts of oxygen, that's when you need oxygen therapy. PIP is positive inspiratory pressure. It measures the pressure of inspiration delivered or when we inhale. And PEEP is PEEP or positive end expiratory pressure. It measures the pressure of expiration delivered or when we exhale. Both the PIP and PEP are measured at mmHg or millimeters mercury. RR is respiratory rate. Normal is 12 to 24 breaths per minute, but sometimes patient would need more than that. Second is the humidifier. It moistens dry oxygen because artificial oxygen is a dry type of air. It is usually instilled with sterile or distilled water with continuous bubbling. Nurses should replace the water as necessary. Third are the tubings. It's the route of air going to and from the client. Air is either oxygen or compressed air. The end of the tubing is directly connected and attached to the client's airway. Now, nurse's responsibility when you're caring for a ventilator, always check for the correct settings as well as availability of gases. May laman pa ba ang oxygen tank or oxygen inlet? Check the water in the humidifier. Is there continuous bubbling? And another important thing is to check for the tubings. Check tube patency and connections na hindi siya nagdi-disconnect because any problem related to this might compromise delivery of air to the patient, especially because not all ventilators have alarms. Mechanical ventilation also uses several separate systems referred to as the mode. In general, the selection of which mode to use is based on what the patient needs or what equipment availability there is at a particular institution. One used mode or one common mode used is the SIMV mode or the Synchronized Intermittent Mandatory Ventilation mode. It delivers a preset tidal volume at a preset rate The patient can breathe spontaneously between ventilator breaths. In short, the machine delivers the breath while also considering the patient's breath. The mechanical ventilation also involves an invasive procedure termed as intubation. An instrument called the laryngoscope is used to create an airway and place an ET tube from the mouth down the trachea. That machine is connected to the tip of this ET tube and gain access down the lungs. Photos above show laryngoscope and endotracheal tube, while the photo below depicts the process of intubation using the above-mentioned materials. Si laryngoscope, yan yung ginagamit para i-visualize ang airway. Makita yung larynx, trachea, that's when the ET tube will be inserted. Because it is invasive, patients requiring this are typically monitored in an ICU. And again, ang ventilators, it is indicated in anticipation of imminent respiratory failure, acute respiratory failure, acute hypoxemia, or sometimes prophylaxis. Because mechanical ventilation also serves to provide assistance for breathing and does not cure a disease. Again, very important that the underlying condition should be identified and treated. The main types of mechanical ventilation are positive pressure and negative pressure. Positive pressure is common where air is pushed into the lungs, while negative pressure is when air is pulled out of the lungs. Once ET is in place, as mentioned prior, when we talked about intubation, the mechanical ventilator tubings can be attached end to end. In the photo, we can see the tip of the ET tube. It's connected or attached to the tip of the ventilator tubing. Mechanical ventilation is often a life-saving intervention, but it carries many potential complications. Number one is barotrauma. Air is compressible but tissues are not. The high lung pressure caused by the ventilator damages tissues surrounding the lungs. Why? Because as mentioned, our lungs is usually accommodating 21% of room air. But if you have a ventilator, it's always more than that. So pressure is higher than the normal. That is why the concept of weaning is very important. Weaning is timing of withdrawal from mechanical ventilation. There are several objective parameters to look for when we consider withdrawal or weaning, meaning unti-unti binababaan mo yung pressure ng FiO2 hanggang sa ma-clear out na siya from the ventilator. There is no specific criteria that generalizes what parameters to consider, but most often, or the most effective and efficient parameter is getting good ABG results or arterial blood gas results. How do we do the weaning? Example, there is an order to decrease FiO2 by 5% every 2 hours if ABG is good or if oxygen saturation is, for example, 95% and above. Another is tension pneumothorax. It's collection of air or gas in the pleural cavity, again due to high pressure of ventilation. In such instances, chest tubes may be inserted to drain. Third, GI complications. Peptic ulcer with hemorrhage, again from high lung pressure. And gastric dilatation from air swallowed due to an artificial airway. That's why insertion of gastric tubes OGT for infants, NGT for adults, it should be inserted. It's a nursing responsibility to assure that an NGT or OGT is inserted when your client has an ET connected to a ventilator in order to decompress the stomach from air. Fourth is hypotension with decreased cardiac output. Again, there is high lung pressure. That's why there is decreased venous return caused by this. But it's only transient. It's important to monitor blood pressure hourly or as necessary. Fifth is increased ICP. Because of decreased venous return, it causes pooling of blood in the head. So we have to watch out for signs of increasing ICP such as headache, blurred vision, decreasing level of consciousness, and one way to address this is elevate head of the bed if indicated or possible. Lastly, there could be fluid imbalance. There is increased antidiuretic hormone from increased lung pressure. This causes water retention. So it's important to regulate intake of food, fluids, IVF, and monitor output such as urine and other secretions. Aside from checking the ventilator if it is functioning well, nurses should always assure that the ET is intact and in proper place. Because even if the machine is working, it cannot deliver ventilation if there is no patent airway. If the nurse assesses that the ET is out, it's not in place anymore, it's not in the trachea anymore, the nurse should call immediately for re-intubation. So how do you check for endotracheal tube patency? 1. Auscultate breath sounds bilateral. Dapat may naririnig ka. Number 2, check if there is equal rise and fall of the patient's chest and ventilator. Remember that one setting in the ventilator is the RR, which means that ventilator setting should equal to the actual rise and fall of the patient's chest. Number 3, monitor for chest X-ray. Chest X-ray is the most definitive way to test if the ET is directly on the trachea. But even if this is the most definitive, hindi ito yung lagi mong aasahan because you cannot do chest X-ray very often. Fourth is observe absence of the vocal sounds. Wala dapat boses ang patient na may endotracheal tube because the ET passes through the larynx or the voice box. Second is hemodynamic monitoring. Hemodynamic monitoring is the assessment of the patient's circulatory status, which describes how blood flows through the cardiovascular system. It includes measurements of the heart rate, intra-arterial pressure, pulmonary artery and pulmonary capillary wedge pressures, central venous pressure, cardiac output, and blood volume. In a typical ICU setting, vital signs monitoring is usually done on an hourly basis, but it may still vary. As often as every 15 minutes or maybe every 2 hours, it depends on the situation. The usual vital signs include blood pressure, heart rate, RR, and temperature. But here we have additional parameters to measure. We'll just consider cardiac output, cardiac index, central venous pressure, mean arterial pressure, and systemic vascular resistance. Now, let us have a very brief review. Hemodynamic parameters are numbers that tell you about the flow and pressure of blood around the body. As a review, Blood enters right atrium of our heart through superior and inferior vena cava. The pressure here is known as the central venous pressure or CVP. Since this is blood returning from the venous system, pressure here is low. Normal is about 2 to 8 millimeters mercury. Blood will then leave the right side of the heart. It will go to the lungs, it will come back to the left side, and is then sent throughout the body. Systemic vascular resistance, or SVR, is the pressure exerted on the vasculature of the body and is what the left ventricle is pumping against to get blood out of the heart. This is much higher, 800 to 1200 millimeters mercury. It's pretty hard to measure though, so we often look instead at the mean arterial pressure or the MAP. MAP is the average arterial pressure throughout the entire cardiac cycle, and it can be easily calculated based on the patient's blood pressure. For adults, normal is 70 to 100 mmHg, and we need a MAP of at least 60 to get perfusion to our vital organs like the brain and the kidneys. Sending that blood forward is the main goal of the cardiovascular system. Cardiac output now is the total volume of blood pumped by the heart per minute. It's the actual oxygenated blood that exits the aorta, around 4 to 8 liters per minute. Cardiac index is that number divided by the body surface area to adjust for different normals and different size of the patients. If cardiac output is low, our organs are not getting enough oxygen. Hemodynamic monitoring may be invasive or non-invasive. Invasive monitoring should include systemic arterial, central venous, and pulmonary pressure measurements. A catheter is directly inserted in either arteries or veins very close to the heart. This poses many complications, especially infection. Another is the non-invasive one. It's a monitoring which includes a standard 5-lead ECG, non-invasive BP measurement, pulse oximetry, among others. Third is on fluid and electrolyte balance. Fluid and electrolyte balance is a dynamic process that is crucial for life and homeostasis. Potential and actual disorders of fluid and electrolyte occur in every setting, with every disorder and with a variety of changes that affect both healthy and ill people. Approximately 60% of the weight of a typical adult consists of fluid. That's water and electrolytes. And the body fluid is located in two fluid compartments, ICF, 2 to 3 or 2/3 of body fluid, and ECF, 1/3 of body fluids. Body fluid normally moves between these two major compartments or spaces in an effort to maintain equilibrium between the spaces. Loss of fluid from the body can disrupt this equilibrium. There are three other types of ECF as shown in the photo. Intravascular fluid, it's plasma. It's fluid inside the blood vessel. Approximately that's 3 liters of the average 6 liter of blood. Another ECF is the interstitial fluid. These are the fluids in the surrounding cells or tissues. That's approximately 11 to 12 liters in an adult. And lastly, another ECF is the transcellular fluid. These fluids are those fluids found in our brain and spinal cord, such as the cerebrospinal fluid or the CSF, pericardial fluid, synovial fluid, intraocular fluid, pleural fluids, also sweat and the digestive secretions. Approximately, that's 1 liter. Electrolytes now in the body fluids are actually active chemicals. Cations carry positive charges and anions carry negative charges. The major cations in the body are sodium, potassium, calcium, magnesium, and hydrogen. The major anions are chloride, bicarbonate, phosphate, sulfate, and protein ions. The table approximates the major electrolyte contents in the body. Please take note that the major electrolyte in the ECF is sodium, while the major electrolyte in the ICF is potassium. What are the major fluid and electrolyte imbalances? We have hypovolemia, hypervolemia, hyponatremia, hypernatremia, hypokalemia, hyperkalemia, hypocalcemia, hypercalcemia, hypomagnesemia, hypermagnesemia, hypophosphatemia, hyperphosphatemia, and hypochloremia, hyperchloremia. I will be showing on the next slides tables of these major fluid electrolyte imbalances, the contributing factors, the signs and symptoms, and laboratory findings. Please review them. They are self-explanatory. Here we have hypovolemia and hypervolemia. Next, we have hyponatremia, sodium less 135 mg per liter, hypernatremia, sodium more than 145 mg per liter. Hypokalemia is potassium less 3.5. Hyperkalemia is potassium more than 5. Hypocalcemia is calcium less than 8.5. And hypercalcemia is calcium more than 10.5. Hypomagnesemia, magnesium less than 1.8 milligrams per deciliter. Hypermagnesemia is magnesium more than 2.7 milligrams per deciliter. Hypophosphatemia is phosphorus less than 2.5 milligrams per deciliter. Hyperphosphatemia is phosphorus more than 4.5 milligrams per deciliter. And lastly, hypochloremia, chlorine less 96 mg per liter, and hyperchloremia, chlorine more than 108 mg per liter. Here are some selected water and electrolyte solutions. The choice of an IV solution depends on the purpose of its administration. Generally, IV fluids are administered to achieve one or more of the following goals. And one is to provide water, electrolytes, and nutrients to meet daily requirements. Second is to replace water and correct electrolyte deficits. And third is when we need to administer medications and blood products. IV solutions also contain dextrose or electrolytes. They are mixed in various proportions with water. But please remember that pure electrolyte-free water can never be administered by IV because it rapidly enters RBCs and causes them to rupture. We have three types of solutions: isotonic, hypotonic, and hypertonic. Isotonic solutions, as seen in the middle photo, has a similar concentration of fluid, sugars, and salt to the blood. That's why RBCs remain normal or the same. Hypotonic solutions has a lower concentration of fluid, sugars, and salt than blood. So as seen in the first photo, RBCs swell. And third, hypertonic solutions has a higher concentration of fluids, sugars, and salt than blood. And as seen in the last photo, RBCs shrink. One significant nursing intervention in fluid and electrolyte balance is actually the correct regulation of IV fluids administered to patients. They are given IV, and the nursing responsibility, of course, is to compute and regulate its rate. Please review computing IVF rates. The formula to get the drops per minute is ml per hour times drop factor over 60 minutes. Drop factor is either macro set or micro set. Usually, macro set is 15 drops per ml, but sometimes, depending on the manufacturer, could be 20, 25, or others. Microset is always 60 drops per ml. Solusets or volume calibrated cylinders are always in a microset drop factor. Also, another interventions is nurses insert IV lines whenever the site is inflamed. So we have to check for signs of inflammation, redness, swelling, heat, pain, and if there's a fluid, it's not regulating well. It's not dropping correctly. So check always for signs of phlebitis or inflammation in the IV site. If it is out, replace. Also, if with IV therapy, always check for potential complications. This include fluid overload. That's why regulation is very important. Checking for air embolism along IV tubings and checking for infection, especially in the catheter site. Here are some selected water and electrolyte solutions, isotonic solutions, another for hypotonic solutions, and lastly, hypertonic solutions. So please read and review them. Next is acid-base balance. Acid-base disturbances are commonly encountered in clinical practice, and identification of the specific acid-base imbalance is important in identifying the underlying cause of the disorder and determining appropriate treatment. An arterial blood gas test or an ABG is valuable in diagnosing acid-base imbalances. These four parameters are usually assessed and measured in an ABG, but there are other parameters that we can evaluate in this test. So what are these usual for? We have the pH or the blood pH. Normal is 7.35 to 7.45. It measures acidity or alkalinity of blood. PaO2 is the partial pressure of arterial oxygen. Normal is 75 to 100 millimeters mercury. It measures the level of oxygen carried by blood for delivery to all cells of the body. Another is the partial pressure of arterial carbon dioxide or the PaCO2. Normal is 35 to 45 millimeters mercury. It's an indicator of carbon dioxide production and elimination through respiratory ventilation. And bicarbonate, HCO3, normal is 22 to 26 milliequivalents per liter of blood. It's an indicator of metabolic pattern in the blood. How do we now interpret this ABG values. If the power of hydrogen is low, there is acidosis. If high, alkalosis. A pH of 7 is neutral. PaO2, if low, hypoxemia. Hypoxemia is low oxygen in the blood, which can lead to hypoxia, which is low oxygen in the cells. This warrants a need for O2 therapy or support. If high, there is good oxygenation in room air. PaCO2 if low, respiratory alkalosis or hypocapnia, seen in physical trauma, anxiety-related hyperventilation, and living in low-altitude areas. Management includes breathing into a paper bag and pursed lip breathing. If high, respiratory acidosis, hypercapnia, seen in emphysema, asthma, pneumonia. Management also includes oxygen therapy or support and giving bronchodilators or corticosteroids to help dilate the airway. Next is HCO3 if low, acidosis, seen in diarrhea, ketoacidosis, certain kidney disorders. Management includes giving bicarbonate. If high, metabolic alkalosis, seen in vomiting, excess ingestion of some medications as well. And management includes IV line infusions of saline, chlorine, potassium, magnesium, among others. Bicarbonate is a byproduct of body's metabolism. Our body brings HCO3 to lungs and exhaled as CO2. The kidneys also help regulate HCO3 because when pH rises, it is excreted by the kidneys, and when pH falls, it is reabsorbed by the kidneys as well. Let us now try to review interpreting an ABG result. There are 7 steps. First is to know the normal values. Second is determine pH. Third, determine PCO2. Fourth, determine HCO3. Fifth, analyze whether the general result is on the respiratory or metabolic side. Sixth, analyze if there is compensation, which is fully compensated, partially compensated, or uncompensated. And lastly, state the final interpretation. So let us discuss them one by one. Step 1. The first step is to know the normal values of pH, PCO2, and HCO3. You need to familiarize yourself with the normal and abnormal ABG values when you review the lab results. They are very easy to remember. Step 2. Determine if pH is normal, acidosis, or alkalosis, and analyze whether general result is probably on acidosis or alkalosis side. Remember in step 1 that the normal pH range is from 7.35 to 7.45. 7.4 is the exact normal value. Please use the diagram to help visualize. So first 2 tables above, it shows a normal finding. However, first upper photo on the left, if the blood pH is between 7.35 to 7.39, the interpretation is normal but slightly acidosis. Next is the upper right photo. If blood pH is between 7.41 to 7.45, interpretation is normal but slightly alkalosis. Therefore, if pH is normal, determine whether the value is leaning towards acidosis or alkalosis side, and then we consider that finding along the way. Let's now go to the next two tables below. Lower left table, any blood pH below 7.35 is acidosis. And the lower right table, any pH above 7.45 is alkalosis. Step 3. Determine if PCO2 is normal, acidosis, or alkalosis. The normal range for PCO2 is 35 to 45. So if below, alkalosis, if above, acidosis. PCO2 is the respiratory determinant. So if pH and PCO2 are on the same side, whether both acidosis or both alkalosis, general result is respiratory. This is necessary for step 5. Step 4, determine if HCO3 is normal, acidosis, or alkalosis. Normal range is 22 to 26. So if below, acidosis, if above, alkalosis. Bicarbonate is the metabolic determinant. So if pH and HCO3 are on the same side, whether both acidosis or both alkalosis, general result should be metabolic. And again, that's necessary for step 5. So here is step 5. Analyze whether the general result is respiratory or metabolic. Considering the first two tables above, if pH is normal, determine whether the value is leaning towards acidosis or alkalosis. So upper left table, we see that the pH is leaning on the acidosis side. PCO2 is acidosis, HCO3 is alkalosis. So this interpretation is respiratory acidosis. Upper right table, we see that the pH is leaning towards the alkalosis side. Bicarbonate, alkalosis, PaCO2, acidosis. So this interpretation is metabolic alkalosis. Next two tables below is very easy because both are on the same side. pH same with PCO2, so therefore respiratory acidosis. Lower right photo, pH is same with HCO3, so this result is metabolic alkalosis. Step 6, analyze for compensation. If it is fully compensated, pH is normal. And then one is acidosis, one is alkalosis. To determine whether respiratory or metabolic, check where pH is leaning, whether leaning on alkalosis side or leaning on acidosis side. If leaning on alkalosis side, PCO2 is there, respiratory. If leaning on acidosis side, bicarbonate is there, it's metabolic. Next, if partially compensated, all three values are abnormal. So in this table, we can see pH and HCO3 are both alkalosis. So the interpretation here is metabolic alkalosis, but partially compensated because the other value, PaCO2, is also abnormal, which is acidosis. Next is uncompensated. It is uncompensated if PaCO2 or HCO3 is normal and the other is abnormal. So here again, we see that pH and HCO3 are both alkalosis. Therefore, the interpretation here is metabolic alkalosis, but it's uncompensated because PaCO2 is normal. Lastly, you state the final interpretation. there are 13 possible final interpretations. So normal acid and base balance, uncompensated, partially compensated, or fully compensated respiratory acidosis, uncompensated, partially compensated, and fully compensated respiratory alkalosis, uncompensated, partially compensated, and fully compensated metabolic acidosis, and uncompensated, partially compensated, and fully compensated metabolic alkalosis. Let us now have 4 examples. Example A, B, C, and D. And to answer each one of them, let's consider the 7 steps. Example A, Step 1, know the normal values. Step 2, what is pH of 7.36? It's normal, but it's leaning on the acidosis side. Step 3, PaCO2 of 51 is acidosis. pH is leaning on the acidosis side. So this interpretation will be acidosis. Step 4, HCO3 is 27, it's alkalosis. Step 5, pH and PCO2 are both acidosis, which means your interpretation is respiratory. Number 6, this is fully compensated. Why? pH is normal. 7, final interpretation, fully compensated respiratory acidosis. Example B, Step 1, know the normal values. Step 2, pH of 7.44 is normal, but it's leaning on the alkalosis side. Step 3, PaCO2 of 30, that's alkalosis. pH is leaning on alkalosis side too, so this interpretation is alkalosis. Step 4, HCO3 21 is acidosis. Step 5, pH and PaCO2 are both on the alkalosis side, so this interpretation will be respiratory. Step 6, this is fully compensated. Why? Because pH is normal. And final interpretation, fully compensated respiratory alkalosis. Example C. Step 1, know the normal values. Step 2, pH of 7.26 is acidosis. Step 3, PaCO2 of 32 is alkalosis. Step 4, HCO3 of 18 is acidosis. Now, pH is also acidosis, so this interpretation will be acidosis. Step 5, pH and HCO3 are both acidosis, so this interpretation will be metabolic. Step 6, it's partially compensated. Why? All 3 values are abnormal. pH is acidosis, PaCO2 is alkalosis, and HCO3 is acidosis. So final interpretation, partially compensated metabolic acidosis. Example D, Step 1, know the normal values. Step 2, pH of 7.48 is alkalosis. Step 3, PaCO2 of 42 is normal. Step 4, HCO3 of 29 is alkalosis. Step 5, pH and HCO3 are both alkalosis, which means that this interpretation will be metabolic. Number 6 or step 6, this is uncompensated. Why? HCO3 is abnormal, but PaCO2 is normal. Final interpretation, uncompensated metabolic alkalosis. Next are pharmacologic interventions. We will be discussing emergency drugs for cardiopulmonary disorders, neurosurgical disorders, poisoning, and shock. It is also necessary for nurses to know very well how to administer drugs, mostly IV push or IV drip. In the first photo, we can see IV push. In the second photo, we can see an IV drip, meaning you incorporate the IV in a solution and then you drip or regulate them, maybe manually or in an ICU setup. Usually there's an infusion pump as shown in the photo. The usual regulation is drops per minute. But if you'll be using an infusion pump like in the photo, there is a regulation of ml per hour. Another important for nurses to know is about drug computation. For slow IV push, or if you incorporate them in an infusion, so again, recall IV rate computation. So ano ang formula para sa drug computation? D over S times Q, or desired dose divided by the stock dose times quantity. And then that's the volume of solution that you will give. First are on cardiopulmonary disorders. So let us discuss some of the basic pharmacologic interventions which are life-sustaining or emergency drugs. Nitroglycerin dilates coronary arteries and improves blood flow to an ischemic myocardium, which is the treatment of choice for angina and myocardial infarction. For acute angina, a sublingual tablet may be used or given every 5 minutes, only up to 3 tablets. It may cause a burning sensation, and that is expected. Second is translingual spray. It should not be inhaled and should not swallow for about 10 seconds after administration to allow drug absorption. Another is a transdermal patch. It is worn all the time, must be replaced only if the old one falls off or if indicated. Avoid placing the patch in hairy areas and keep self away from strong electricity. Now, nitroglycerin can also be given as an IV infusion or IV drip, but it is reserved only for unstable angina and acute myocardial infarction. In the photo, we can see different preparations of nitroglycerin. The uppermost photo are nitroglycerin sublingual tablets. In the middle photo, ampules for IV. The lower photo, first picture, is a vial for IV. Middle photo, in the lower part, is a transdermal patch. And the last, at the lowest part, is the sublingual or the translingual spray. Nitroglycerin decreases blood pressure, and combining it with drugs for erectile dysfunction can cause profound hypotension in a 24 to 48 hour period, so monitor very well. Morphine sulfate is a narcotic analgesic to treat chest pain with acute MI and acute cardiogenic pulmonary edema. It reduces pain significantly as it effectively dilates venous vessels and reduces workload in the heart. It's given 1 to 4 mg IV over 1 to 5 minutes every 5 to 30 minutes until chest pain is relieved. Morphine sulfate may cause possible respiratory depression and hypotension. Now, a readily available antagonist may be given for respiratory depression, and that is the narcotic antagonist naloxone. It should be ready on hand, can be given 0.4 to 2 milligrams every 2 minutes as indicated. In the photo, we see the above ampule and vial of a morphine injection could be given sub-Q, IM, or slow IV push. But in cases of emergency situations, life-threatening conditions, for example, IV is the best route. The lower photo is an oral morphine. Another is atropine sulfate. It's an anticholinergic drug indicated for treatment of hemodynamically significant bradycardia, heart block, and asystole or pulseless electrical activity. It increases heart rate as it inhibits cranial nerve 10 or the vagus nerve. Adult IV should never be less than 0.5 because it can cause paradoxical bradycardia. Ideally given IV but may also be given sub-Q, IM, IO, and ET route. There is also an atropine ophthalmic ointment, but it acts as a mydriatic or for pupil dilation, especially during eye surgeries. Asymptomatic given IV at 0.1 to 1 milligrams at 3 to 5 minute interval until desired heart rate is achieved or until 0.4 mg per kilo is given. Asystole, meaning no heart rate at all, given 1 mg bolus followed by a 20 ml fluid bolus and elevation of extremity every 3 to 5 minutes until 3 mg IV was given. Lidocaine treats irregular heartbeats and exerts a local anesthetic to the heart, thus decreases myocardial irritability and given IV or IO or intraosseous. There is lidocaine toxicity. Watch out for confusion, drowsiness, hearing impairment, cardiac conduction defect, or dysrhythmias, myocardial depression, muscle twitching, and seizures or convulsions. If there is toxicity, immediately stop if there is an infusion. Those with hepatic impairment, heart failure, shock, and advanced age are at a higher risk for toxicity, so dosage for them may need to be reduced. There is also a lidocaine topical cream or spray, usually for minor surgeries. Epinephrine is a catecholamine with alpha and beta adrenergic effects. It is very good for bradycardia, hypotension, asystole, pulseless ventricular tachycardia, and ventricular fibrillation. It improves perfusion of the heart and brain, especially during cardiac arrest, because it constricts peripheral blood vessels. During CPR, it's usually given every 3 to 5 minutes in a span of 15 minutes. But if there is still no heart rate, like let's say for example, after 15 minutes, CPR may be stopped and the doctor may decide to declare the client as dead. This can cause myocardial ischemia and cardiac dysrhythmia. That's why it should never be given in the same site as alkaline solutions like sodium bicarbonate. If it is 1 per 10,000, single dose of IV or IO route, 1 per 1,000, continuous infusion can be given IM or sub-Q route. Sodium bicarbonate treats metabolic acidosis, but given only if adequate ventilation, chest compression, IV fluid, or other drug therapy fail to correct the acidotic state. Catecholamines such as epinephrine, norepinephrine, and dopamine are inactivated by sodium bicarbonate. That's why we should consider giving the drug if the patient receives the following medications. Careful monitoring of ABG should also be done. it's given as an IV, but there is an oral preparation of sodium bicarbonate for a different indication. It may act as an antacid, but here we are considering it as an emergency drug for metabolic acidosis. Sodium bicarbonate should be given cautiously because it can cause IV burns. So we should take note that you give it and monitor the IV site properly. Next, on neurosurgical disorders. Mannitol is an osmotic diuretic to treat cerebral edema and increase intracranial pressure. So this drug decreases ICP. This may occur following a head trauma, neurosurgery, and other intracranial pathology. It may be given as an IV bolus or via continuous drip, but is very highly irritating to the veins. That's why when you give it as a drip, there should be a filter because crystals may form in the solution. Mannitol, again, is given as an IV infusion. Methylprednisolone, high doses may be administered as an option to clients with traumatic spinal cord injuries. Its efficacy in reducing sensory and motor deficits is not yet supported, however, but it must be given within 8 hours after an acute spinal cord injury to achieve the best effects. Methylprednisolone is given IM or IV. On poisoning, naloxone, sub-Q, IM, IV, and IO preparations reverses effects of opiate drugs such as morphine, meperidine, codeine, and heroin as they competitively binds to opiate receptor sites in the body. So when do you give naloxone? When there are obvious manifestations of respiratory depression. Same with flumazenil. It also reverses respiratory depression and sedative effects of some benzodiazepines such as diazepam and midazolam. Activated charcoal is prescribed for poisoning as a means to prevent absorption of toxins into the body if the ingested substance is known to be affected by charcoal in the GI tract. It can be done using a gavage or lavage. Last are pharmacologic interventions for shock. There are several drugs given for shock, but let's consider these two. Dopamine is a sympathomimetic agent to treat hypotension caused by hypovolemia. It enhances cardiac output by increasing myocardial contractility, increases heart rate, and elevates blood pressure through vasoconstriction. Because dopamine is very good when it comes to vasoconstricting blood vessels, dopamine is best for distributive shock. As a review, distributive shock is an altered tissue perfusion level caused by severe vasodilation. Dobutamine, on the other hand, is a sympathomimetic drug also with beta adrenergic activities, enhances flow of myocardial contraction, increases heart rate, and produces mild vasodilation. It's indicated in shock states when improvement in cardiac output and overall cardiac performance is desired. And because it improves heart performance, dobutamine is best for cardiogenic shock. Both medications, as shown in the photo, are given as IV infusions, and they are usually incorporated in solutions of IV fluid. That's the end of the lecture discussion. Thank you very much.